sure of my dates because I'm just kind of time warped at this moment, but the mayor here in Baltimore City announced that there was going to be another task force put in place. And my operative word there is another task force.
Yeah, right.
Because we have so many programs that actually work and work well across this nation and also around the world. We already know what will work. It is will we put behind it the muscle that is needed? Will we put the money behind it? And will we identify and educate and inform everybody across the world that it is that you don't point your finger at me and say, well, you did this to yourself. Why should my tax dollars go to it? And then you all of a sudden wake up one day and say, I need to put my tax dollars behind it because it's my wife, it's my husband, it's my son or my daughter. Our mayor says that there are 10,000 addicts in Baltimore City. But there are other records that say there are as many as 60,000. However many there are, it is now time that we must, if Narcan is available, it should be available in the hands of every person that is an active substance abuser, that is an active injection drug user. There should be a safe house, the same as there is in Vancouver. There should be one in every city and every region to make certain that you are able, that we are able to get the help that we need when we need it. Because I want to get clean in the middle of the night and everything is locked up and locked down. It is wrong. I need counseling because what drove me to a place of looking for some euphoria in the first place was probably the fact that I had a deep-seated pain that I could not handle, and I needed someone that had the experience to be able to do what? To listen to me. The first responsibility of any counselor, of anyone that really cares, is to listen. Responsibility when you leave this room and you go to the various sessions is to listen. And then after listening, ask the question. May I ask a question? And if I can ask a question, then I want you to listen to my question. And my question is that how do we form legislation? How do we get the dollars that are going to penetrate that which is taking place and is continuing to take our family members out day in and day out? There is no 24 hours where death does not visit because of substance use and abuse. There is no place where they can say they can call home. And I keep using, I really go back and forth between they and we because I have to remember, even though I've never misused a drug in my life, I'm an addict. I'm an addict, and I admit that I'm an addict, and I'm just a different type of addict. My substance is shopping. My substance might be men. Hey. Right now, so you know. But at any rate, to keep it real for you, to keep it real that there is no us and them, it's just us. That we all need to walk with each other. You have a responsibility to listen, to ask questions, and to formulate what is the solution from where I just said. How do I make certain that it goes back and it is usable in the places that I work, that I live, that I care about? We have a responsibility to knock hard on the community doors, the faith community's doors, to say, open your doors up. That you might need to be that place that looks like Vancouver. We have the responsibility to go and make certain that people know where the resources are, that they know how to check in on those that are going through places that many of you have already come through. There is a lot of need to advocate, and advocacy is the biggest part that you must leave here with. Choose your road of advocacy. Is it advocating in Congress? Is it advocating in your local city council districts? Where is it advocating at? And bringing along someone with you. Here in Baltimore, we understand that there is an intersection between substance abuse, injection drug use, hepatitis C, and HIV. We understand if we can get those things under control, then we can reduce the mortality rate. We understand that needle exchange has been exceptionally well done here in Baltimore City since 1984. We understand that injection drug use puts many at risk for hepatitis C as well as HIV. And we know for a fact that many don't know that they have hepatitis C, that their liver is frying on the inside that they cannot see, and that they're afraid to get tested. You're afraid to get tested for HIV, you're afraid to get tested for hepatitis C, but we must do a better job and bring those numbers down to everybody having been tested. So as I come to a close on my presentation, because I don't need to hold you up from getting to your workshops, I implore you to go with a passion in your heart that nobody will shut you up, nobody will sit you down, that we will have a safe house in every city, in every state, that we will have Narcan available to every injection drug user, that we will do better at advocacy, because who are you? You are the agents of change. Obama said that he was the agent of change, but the agents of change are in this room, and you must do it, and I pray that the next time we all see each other, you remember my face, you remember that I might still not have a man. Don't introduce me to just anybody. Make sure he's somebody. And that whatever you do with a passion, and you make certain that our youth are involved and you stay non-judgmental. It is not about male versus female. It is not about black versus white, skinny versus fat. It is about people. It is about all of us. And life is critical, and it hangs in a balance. We cannot continue to be a people of contradiction, and we don't have not one more damn year to get it together. So have a blessed and wonderful day.
You see why everyone loves Reverend Hickman in Baltimore. Two more housekeeping announcements. The agenda has changed. If you are savvy enough that you can scan this, you'll get the agenda. It's on the back of your current agenda, the old agenda, or go talk to someone at the registration desk. Secondly, there are photographers all around, and if you don't feel, be friendly to them. But if you don't want your pictures taken, let them know, and it's fine, of course. All right, so we're now moving on to New York, as if we didn't have enough New York this morning. We love New York. It is my pleasure to introduce Charles King from Housing Works. Charles King is one of the founders of Housing Works. He's the president. Housing Works is a CBO that provides a full range of services, including housing, healthcare, mental health, chemical dependency services, legal advocacy, job training, and employment for homeless men, women, and children living with HIV/AIDS and other chronic conditions. Charles serves for the governing body of UNAIDS as a member of the NGO delegation to PCB and co-chair of the New York City End of AIDS Task Force, the New Great Task Force. He has a law degree and a Master's of Divinity from Yale, and is an ordained Baptist minister. So, I'm looking for him now.
Thank you so much. It's a true pleasure to be here this morning. I realize that I have something in common with Reverend Hickman other than being an ordained minister, and that is that my substance of choice is men. Fortunately, Reverend Hickman, right now I happen to have one. I'm not about to share. June 29th of this year, Governor Andrew Cuomo made what I hope we will look back on as a historic announcement, in which he committed New York State to be the first jurisdiction anywhere in the world to end AIDS as an epidemic. He committed to a date specific by which we will have ended AIDS as an epidemic, and that is 2020, almost 6 years from now. And he based this commitment on 3 pillars. The first, identifying people who are HIV positive, unaware of their status, and getting them into care. The second, engaging everyone who is HIV positive and known to be HIV positive in treatment, such that they are completely virally suppressed, taking care of themselves and ensuring they can't pass the virus to others. And third, scaling up new prevention technologies such as pre-exposure prophylaxis to prevent people who are at highest risk of HIV infection of ever getting infected. Now, I want y'all to know that it's really not the case that the governor just woke up on one warm day. The idea of ending AIDS as an epidemic started a little over 2 years ago, and the source, the actual place where the idea started was a jail cell inside Washington, D.C. There was a big demonstration outside the International AIDS Conference that was held in Washington 2 years ago, and there was a call put out for executive directors, presidents of AIDS service organizations to be willing to engage in a symbolic civil disobedience in front of the White House. See one of my friends who went to jail with me that day. And the fact of the matter is that Mark Harrington from Treatment Action Group and I were the only heads of AIDS organizations who stepped forward. So we gathered some friends, and 14 of us were arrested that day. Mark and I were put in the same cell together, and one thing that we have in common is we have both been serious critics of the National AIDS Strategy. I call it a strategy to maintain the epidemic, not a strategy to end the epidemic. And we kvetched for as long as we could, sitting in that cell, about how all of the weaknesses and failures of the strategy. And then Mark said to me, Charles, do you think New York could be the first state to end AIDS as an epidemic? And that set me back. It was no longer me talking about what they were doing wrong in Washington. It was more like what we were going to do about it. But I started thinking about it, and you know, for over a decade I've been traveling around the country saying, we have the science, we have the technology, even without a cure, even without a vaccine, we can end AIDS as an epidemic. It's not even that we lack the resources, what we lack is the political will.
That's right. That's right.
So now I get challenged, do we have what it takes to do it in New York? Well, there were a couple of things that I thought made it look like we did have what it takes. One is that under Governor Cuomo, we started out a design to redesign our Medicaid. And I have to tell you, I've been working in healthcare for many, many years now. Every governor comes in and wants to redesign Medicaid because it costs way too much money, et cetera, et cetera. And for the first time, we had this open and inclusive process where anybody could come forward with ideas that would do two things: improve health outcomes and reduce costs. And I can tell you, we actually saw some things get some real traction. And not everybody likes everything that came out of the process, but some really great things came out of the process. For example, in New York State now, you can get a license to do drug treatment using a harm reduction methodology. No longer are we as a treatment modality. In addition, if our state plan amendment gets approved, and it's sitting over at CMS right now, all of our state-funded harm reduction programs are now going to be funded through Medicaid for everything that they do except the actual provision of the syringe, which, as you know, Medicaid can't pay for until we lift the federal ban. So we started thinking, wow, there's a real opportunity here to use that. Then there's something called the global cap on Medicaid, which was a real innovation that said, you know what, if you save Medicaid dollars, we're going to cap the state at a certain amount of Medicaid spending, and we're going to give the commissioner this stick to enforce that, where he can just cut rates, cut anything else. But if you save Medicaid dollars, instead of us just pulling that back into the state's coffers, what we're going to do is we're going to allow you to use that money in other ways to improve health outcomes that will reduce costs. As a result of that cap, over the last 2 years alone, New York State has invested $230 million in state share Medicaid savings to provide housing for people with chronic disease. About that is, for the first time, we're saying that for people with chronic disease who are homeless, housing is a medical intervention and should be paid for using health insurance dollars. And that's a big step forward. The other things that made us think that we had this opportunity to do something transformative in New York was the Affordable Care Act, and the fact that we really believed that New York State was going to buy into it hook, line, and sinker. And we did. And we've taken advantage of many, many of the provisions of the Affordable Care Act. First of all, because we've done the scale-up of Medicaid and taken advantage of some of the other provisions, we put in place our own health exchange, we're finally at a place where almost every New Yorker has access to health insurance. Now, this is no substitute for a single-payer system that it automatically insures everyone, but for the first time, we're in a situation where 90 to 95% of residents of New York State can have insurance that can pay for preventive health, including preventive health around HIV. And that's amazing. But then there's other things that we've taken advantage of, like health home, DSRIP. I won't go into it, it's way too complicated and boring. But really, really important. And then last in the political will arena was we were in the middle of a mayoral election. And after having been through a number of years of Rudy Giuliani and a number of years of Michael Bloomberg, we thought we might have a chance to get a really progressive mayor who would be open to changing the way we address HIV, the way we address drugs, the way we address all of these things in our community. And I think what we've seen is we actually have elected exactly that kind of mayor, and that's a major step forward. So we started organizing a campaign, and I won't go into all of the elements of the campaign, but what I can tell you is that this campaign was successful in leading the governor to make his announcement, the announcement that he made on June 29th. Now what has happened is that a task force has been appointed. Now I can tell you I have a long history with Andrew Cuomo. I think he has hated Housing Works just for the fact that we came out of APTA. I can tell you a couple of demonstrations that we did towards his father that particularly insensitivity. I remember going in drag up to Albany with a big wig. It was my own hair piled up. Back then I had longer hair than I have now. Distributing M&M's cake crumbs and wearing Mario masks that said, "Let them eat cake." So he doesn't have that big a reason, but he's got a long memory. But he did ask me if I wouldn't co-chair this task force to bring an end to AIDS. So we're right now in the process of cobbling together some recommendations that we're going to be presenting, and I know that just this week, next week alone, some 60 recommendations are going to be loaded up into a system so that the task force has the material to work with to produce a report in January that we will be giving the governor to tell him what he needs to do around these 3 pillars in order to end AIDS as an epidemic. It's going to be an open process. You don't even have to be a New Yorker to participate in the process. I wish I had the website to give up to you now, but I don't. Hopefully by the end of the week we'll have the website up, and anybody, anywhere, can go on to that website, log in, and give us your ideas about what we need to do to end AIDS as an epidemic. So how do we know that we've ended AIDS as an epidemic? What does that mean? Well, there's some scientific stuff around this. We're not just making it up. One is to get to a viral replication rate of below 0.5%, which what the state will tell you is we're now down below 3,000 new infections. We peaked at over 8,000 new infections a year. We're now down below 3,000 new infections a year. We got to that viral replication rate, we'd be down below 750. But if we got to that viral replication rate in every single high-risk population, we would be down below 250 new infections a year. And that would be a pretty amazing thing. And with drug users representing right now 5% of all new infections, that would mean something like less than 3 new infections as a consequence of injection drug use in New York State by 2020. And that really is our goal. The second thing is that we want to get to a point where we're at 0 AIDS mortality. And that means 0 people dying with HIV as the primary cause of death. Now, for those of you who are HIV infected, like me, I have bad news for you. We're still going to die. We haven't solved that one, but we're not going to die of AIDS. We're going to die of the same thing that everybody else out there is dying. But we also want 0 AIDS stigma. We need to end stigma if we're going to end the epidemic, just like we need to end stigma against people who use drugs if we're going to end the epidemic and all the problems that come from drug addiction. And we're setting a living well metric. And part of our living well metric, it has 3 elements. One is that yes, every single person who's HIV positive is on treatment, completely virally suppressed so that the disease isn't progressing in their bodies. But 2, that every single person have a safe, secure place to live. And 3, that every single person living with HIV have food security and vocational opportunities available to them. So that's how we're measuring that we're ending the AIDS epidemic. Now here's the deal. I've only got a couple of more minutes to wrap up. But the reason I'm here telling you about this is not to brag about what we're doing in New York State. We're actually taking a big risk by putting ourselves out there and saying we can make this happen. I'm here today to say to you that if you are from New York, jump in the process, get involved, help us make it happen. But if you're not from New York, go back to your own state and ask, can we end the epidemic here, wherever you're from? Because if we don't start talking about ending AIDS as an epidemic, it will never end. We're at this critical juncture where we actually have the possibility of bringing the epidemic to an end. And if we seize on that juncture, we can make it happen. If we don't, let me tell you what's going to happen. AIDS is just going to become another chronic disease that will continue to be as an epidemic only in certain marginalized populations. And that means men who have sex with men, especially young men of color, transgender women, and people who use drugs. And so we need to seize this moment and show that we can end AIDS as an epidemic. We not only need to seize it so that we can show that we can end AIDS as an epidemic and so that we can keep it from becoming this lingering, festering epidemic in marginalized populations, but because if we prove that we can end AIDS as an epidemic here in the United States, then we can show that we can end AIDS as an epidemic around the entire globe. But for me, it's never been just about this virus. Because after all, HIV is just a virus. And one day, there's going to be another virus that comes along. And we've already seen that with hepatitis C. And so what we need to be looking at is ending AIDS as an epidemic in a way that transforms our systems such that when the next virus comes along, ready to take advantage of our own inhumanity, we can respond with a response that is embracing, that is accepting. And then I want to give you one more reason why I think it's important for us to end AIDS as an epidemic. You all participated earlier in a moment of silence in which you shouted out the names of people who we've lost, who've been a part of the harm reduction movement. Three of the names that I heard being shouted out were not only leaders in the harm reduction movement, they were leaders in the fight against AIDS from New York. My partner of 15 years, Keith Kyler, Joe Bostic, Joe Papastani, both co-founders of Vocal. I think it's important for us, if we really want to honor the people we've lost in the fight against AIDS, to finish the work that they started out.
That's right.
The fact of the matter is, coming to these conferences in the past, there were people in this room who literally gave their lives to fight AIDS and HIV. Back when there was no treatment, when there was no prevention but condoms, when there was just one drug, AZT.
Amen.
And even after we had combination therapy, but it was too late for them. And we owe it to those people to bring an end to AIDS as an epidemic.
Yes!
I want to conclude just by sharing the remarks that, the last paragraphs of the remarks that I made at the opening of the End of AIDS Task Force. 30 years ago, AIDS forced me out of the closet as a young gay Baptist minister, standing at the bedside of our minister of music who believed God was punishing him because of his sexual orientation. After leaving my position at Emmanuel Baptist Church, I, like so many others, eventually found myself in the LGBT Community Center in the West Village of Manhattan on a Monday night at a meeting of ACT UP New York. Sometime later, in October of 1988, I joined some of the people who are in this room on a trip to the Federal Drug Administration that changed the course of the epidemic. The day before the now famous demonstration, we gathered for a not-so-well-remembered rally in front of the headquarters of the United States Department of Health and Human Services. It was there that I heard Vito Russo articulate a vision that I've held on to as my personal calling ever since. Someday the AIDS crisis will be over, he said. Remember that. And when that day comes, when that day has come and gone, there will be people alive on this earth Gay people and straight people, men and women, black and white, who will hear the story that once there was a terrible disease in this country and all over the world. And that a brave group of people stood up and fought, and in some cases gave their lives, so that other people might live and be free. And then, after we kick the shit out of this disease, we're all going to be alive to kick the shit out of this system so that this never happens again. To me,
ladies and gentlemen, real quick, I'm going to have my fellow board member from local New York step up for a second. Robbie told me. I'm sorry, hold on one second. I apologize.
Okay, soon, one more speaker. All right, we are leaving the East Coast and going to the island of Puerto Rico. Dr. Carmen Albizu-Garcia is a Puerto Rican physician who since '92 has been a harm reduction and drug policy advocate. She organized the first drug policy reform meeting in Puerto Rico. She's done a lot of advocacy around overdose prevention, methadone expansion, and it is our pleasure to welcome her to the Harm Reduction Conference. Come up to the podium. Thank you.
Okay, hi, good morning, buenos dias. Buenos dias. How many here are Puerto Rican? Okay. Now, just bring down your hands and just raise them if you're an island Puerto Rican. Okay. Yeah, so hold on for a second because I have to open my presentation. And let's see. Okay, so I want to start by thanking the conference organizers. This is such an energizing group, and for someone like myself who, after you hear us today, has to think about how is it that we can keep up hope and not become cynical. I really appreciate sharing with you not only your energy but your commitment, and I thank you all for all the great work that you are doing. Now, I've been asked to talk about the Forgotten Island, and I decided to subtitle my presentation Health Disparities Among Puerto Ricans Who Inject Drugs, because the title itself, I didn't want it to suggest at all that we were going to talk about the land that time forgot and how another Jurassic Park had ended up in the Caribbean. But in reality, there is that feeling that we're still in a prehistoric age when it comes to addressing both drug use and the HIV and Hep C epidemics in the island. So I'm going to share with you some information. And I want to first acknowledge the many collaborators I've been working with throughout the years that have been doing work in this area and whose information informs as well as presentations. So Puerto Rico, as you know, is sitting there in the Caribbean, the smallest of the Greater Antilles, and initially a Spanish colony, and after the U.S. won the Spanish-American War, we became a U.S. territory. And it's important because we are a little forgotten, even from a government standpoint, because Puerto Rico is not a state, obviously. And as a territory, we do not participate in presidential elections. We do not have voting representation in Congress. And therefore, we rely a lot on advocacy work from people that feel for us and help us out in channelizing our woes to elected Congress people in the United States. So we have a mix of the old and the new. And, okay. But the reality is that recently the National Public Radio developed a series of programs that they titled Puerto Rico, a Disenchanted Island. And 3 programs stick out here. One that was titled, Don't Give Up on Us. Puerto Ricans wrestle with high crime, so crime is a concern. The second, Puerto Rico's battered economy, the Greece of the Caribbean, so deceleration and lack of economic growth is a concern. And the last one, one-way tickets to Florida, Puerto Ricans escape island woes. Now, what we are facing in Puerto Rico right now is a dwindling population. Projections from the Puerto Rico Planning Board, based on U.S. Census data, tend to sustain that we're going to be pretty old pretty soon, because the population 65 and older is projected to duplicate by 2050, whereas people between the ages of 0 and 14 are going to become halved. So who's going to inject energy into the workforce and pay taxes and help sustain all the important social institutions and health institutions, education that the country needs to generate human and social capital? That's a big question, and one that worries people a lot. But what I would venture to say is that the problem that we face, although complex and multifactorial, is greatly influenced by a very misguided drug policy approach that has been implemented in Puerto Rico since the 70s, when the drug problem became more evident. We have basically a supply side policy, and today it took me by surprise that I could stand up and participate in a standing ovation for the director of the Office of National Drug Control Policy at the White House, because I have booed Barry McCaffrey and I have booed other people in those positions, and so I'm really happy to see that at least from a policy perspective there's some hope. But how does that affect us? Well, Puerto Rico, when we look at prevalence data of drug use in the island for the year 2008, and just look at the illegal drugs here on the second bullet, 20% of adults, of people between 15 and 74 who participated in this island-wide survey reported ever having used an illegal drug. And that is a 250% increase from 1987, when the data was collected previously. 250% increase. And when we look at the illegal drugs prevalence over the last 12 months, it was 7.6%. Now, when we look at people that have a substance use disorder, what we find is that those that, this is using the old criteria of abuse and dependence, nearly 2% of those drug users fulfill criteria for drug abuse, compared to 1.4% in the US around 2006, and in terms of dependence, 2% compared to 0.6% in the United States 2 years previously. So when we face the situation of drug use, more people use drugs, illicit drugs in Puerto Rico, and of those who do, more people than in the United States aggregate population have a drug problem. Now, when we look at the population with current drug dependence, of those, 44,000 are heroin users, and of those 44,000 who use heroin do so through injection. It has been estimated by the DA of the federal government in Puerto Rico that the cost of daily consumption comes up to nearly $3 million, and that if you are not resourceful, if you're resource poor and you have to steal in order to obtain resources to purchase the drug that you consume, it requires nearly $7.4 million of stolen property per day. In this enchanted island of 135 air miles that sits in the beautiful Caribbean Sea. So you can see how by allowing drug use, consumption, and substance use disorders to escalate in frequency, and particularly as people are socially excluded and become resource poor, the fact that the policy is tied to crime becomes very obvious. Now, this might be a little busy, but basically this is a comparison of treatment availability and utilization for substance use disorders, 1998 and 2002. What is basically important about this figure is that the table reveals that between 1998 and 2002, all capacity decreased. In terms of treatment for primary alcohol problems, a decrease of 39% in treatment capacity. For illegal drugs, 41.6%. So treatment capacity was halved over those 4 years. And of that capacity that was utilized, the utilization rate dropped by about 10%. And obviously, as treatment facilities are closed down, also service staff also reduced, and almost a third less by 2002. Now, you would think that there ought to be some connection between having need for care and providing care. So this is another problem, because we see then that the policy response has not been demand reduction. Now, if you compare the treatment capacity by treatment modality, this presents 4 different types of treatment modalities. Residential to the left, intensive ambulatory, and medication-assisted treatment. And the greatest growth is in residential treatment, which is definitely the most, I'm trying to think of the word in English, but basically the one that we need the least, because we should be able to have medication-assisted treatment given our heroin problems. Out of the 40,000 heroin users in Puerto Rico, there's barely a capacity to treat about 7,000 or 8,000. So, the other thing is that these residential treatment facilities are the less utilized, and we'll see in a little bit why, whereas medication-assisted treatment is filled to capacity and has waiting lists. Now, this is our treatment gap as it has existed since 2002. We had a little bit of increase in buprenorphine treatment in Puerto Rico from 2009 to the current stage, and approximately 2,000 plus slots of buprenorphine treatment have been made available. But you see that this gap is nearly 92%. Now, what have been the consequences of not providing treatment and other harm reduction measures? This is a very sorry situation. This is not an infrequent occurrence that we see people in the street that are homeless and that have serious health problems associated to the conditions under which they end up having to use the drugs that they use. Now, what happens? Puerto Rico is a small island, and the response has been, hey, let's move the police, let's move the National Guard, let's just fight the drug war to the tits, and let's just get out there and fight. And this has been part of what happened. Look at the results. Because the illegal market is not well consolidated, every time we have police activity of the community and more raids in drug selling areas, what we do is we generate movement of drug selling points to other parts of the community and turf wars for control of the drug sales. So our homicide rate is not a problem that is primarily caused by other sources of interpersonal violence. It's really basically a product of the market, of that illegal drug market that settles their scores, not in the courts, but on the streets and with violence. Add to that we have an open access to the United States where you have firearms galore, and so it's very easy, in spite of our very strict laws regarding firearms possession, to have firearms come into the island and support these drug wars that are taking place constantly. Now, HIV/AIDS, and I'm very taken by what was said in the previous presentation, but I have news for New York. We have a big AIDS problem still, and I don't see it abating very shortly. This is from the CDC, and I just want you to look at the second column from the left, which shows the proportion of HIV/AIDS diagnoses among male Hispanics by place of birth, and this in particular is a column for Puerto Rico. The yellow portion of the bar indicates the proportion of cases who acquired through injecting drug use with contaminated equipment. So we see that Puerto Rico has a larger proportion of injecting drug use as the primary mode of containment for HIV in the island. AIDS mortality. Puerto Rico has 6 times greater case fatality rate than that for the aggregate U.S. population of approximately 5 per 100,000. We have fluctuated between 26 and 31 per 100,000. That is totally unacceptable.
That ain't right.
No, it isn't. No, it isn't. Now, we also have a burden of hepatitis C. Hepatitis C reporting, although mandated by legislation since 2003, there is really yet no effective surveillance system in place. And we do have data from a population survey conducted between 2005 and 2006 that did not only self-report and risk behaviors, but serologic testing. And the prevalence in the general population was estimated at 2.3%. But among people who reported a history of injection drug use, it was 76%. Okay? So this is terrible because A, the majority of individuals were unaware of their serostatus, and B, as happens still almost in the United States, there's not treatment going on for those affected. What we see then is a trend in the increase of cancer due to chronic hepatitis C infection. Hepatobiliary cancer mortality trends are creeping up. And this is data from the Puerto Rico Cancer Registry. And I'm sorry that this slide is in Spanish, I forgot to translate it, but basically we also have a high incarceration rate that is still not as high as that of the United States, but it is higher than that of the average for the Latin American region. The other thing that, since we invest so much money on supply side activities, we have an enormous amount of policemen per population. Here, from the UNODC data for 2013, we find that Puerto Rico, on the bottom, has 511 police officers per 100,000 population. That is nearly twice, more than twice that of the USA and Canada. And you can see from these numbers that it is much higher than Western Central Europe, Latin America, and the rest of the Caribbean, and Eastern Europe. So we've been putting our money where it is less effective, at great harm, And this is a comparison of the budget for the State Mental Health and Substance Abuse Agency, which is on your extreme left, the tiny, tiny amount. And for the between 2011 and 2013, actually now their budget has been cut further, has been, they have not gotten sufficient funds, whereas the Department of Corrections, the police, are getting more money, particularly the police, and you can see that their budget has been rising consistently throughout this period. The last group of columns on your right corresponds to the court system. So, how is it that we can continue with this misguided policy? What's behind it? And of course, there's lots of reasons. It's not all that simple. Much of it comes from the fact that there is an investment in those people that benefit from the drug war. There's a legal sector of the economy that benefits from the drug war, the drug testing, the criminal justice system, the DEA, the police, the correctional officials, you name it. Fortunately, we don't have any more private prisons. That's a good sign. But basically, in addition to that sector, how else can we explain the persistence of misguided policies for decades now? And so, I tell you guys, I come here, and it's so refreshing to see that there's actually opportunities to move along. So basically, we really feel that stigma really underlies a lot of it. Because stigma involves social disapproval and discrimination of individuals that bear a discrediting mark. And when you look at what we know about stigma, we know that stigmatized persons are viewed negatively due to traits that are loathed, feared, or socially devalued. And that not only that, but they become their social identity. It's not like you talk about this person as the hypertensive, but you do talk about the drug user. If stigma is exercised through power differentials, and if there's any place where a power differential exists, it's, for example, in drug treatment. 80% of people that go to treatment go so mandated, yeah? So there is a big power differential. It's a criminalized condition. And when your stereotype is only serving you're at risk of social exclusion, loss of status, health inequities, and premature death. So, stigma towards drug users, the work of the WHO shows that it's pervasive across the world. In a study in the eastern half and the western half of the world, in many countries, stigma towards drug users was high up on the list, much more so than stigma towards people that kill someone, or even against people that live with HIV. Now, this widespread stereotype, it's not just something that happens in person-to-person interactions in society, it has permeated policy. It sustains policy. It is because I remember hearing congressional hearing once, maybe about 9 years ago here in the United States, where they were saying, hey, we can't give money for drug treatment because that sends a wrong message. If you tell people that there's treatment there, that will not dissuade them from initiating their use because they think they can actually get easily out of it. So stigma does underlie policy decisions, and the worst part is that health professionals, the serving professions, as happens with what we know, let's say, about medical care for people with different ethnic race backgrounds, what we know about how there are disparities in health outcomes when Afro-Americans or Latinos go to a doctor with the same condition as a non-Hispanic white, and because the expectations that providers have about how this person can understand, adhere, or participate in treatment might be different through stereotype, the results are different. And that has been well documented by the Institute of Medicine. We know that happens. So why should it be different for something that is loathed so much more, which is illegal drug use? And basically then, we not only have stigma operating at the policy level, we have it operating within the professional sector, within physicians, and as has been reported for people living with HIV, fear of stigma from the health services sector may deter utilization and affect outcomes. So, we did a study with providers. We looked at 666 students and practicing professionals in medicine, nursing, social work, and psychology, and found that there's been a middle progression in the sense that 70% agree that addiction is an illness like any other. So if it's an illness like any other, do we treat it like any other illness? Well, no. Nearly 50% believe that one of its main causes is lack of self-discipline and willpower. Nearly 40% agree or are uncertain that addicts are a burden to society. Nearly 70% agree that as soon as a person shows signs of a drug addiction, that person should be required, mandated, to get treatment. I don't know if anybody here has hypertension or diabetes or asthma. I'm suffering the aftermath of an asthma episode in Florida from all the pollen during these last few days. And I tell you, why should I be forced into treatment? Why should I be coerced into treatment just because I have a sign of a condition? 50% of the respondents agree that there is something about individuals with drug addictions that make it easy to tell them for people who don't use drugs. So stereotyping and social control are prevalent in this group. One of the other responses that I did not include in this slide is that when asked if they would support that someone with an addiction enter a public office, that nearly 70% disagreed. So it's not just let's have a lot of social control. It's not just that we stereotype them, but also they are untrustworthy for the rest of their lives, and they don't even merit occupying public office. Now, we looked at 132 entering graduate students in the health profession, and they were given a sentence completion exercise. They were told, complete a sentence that starts out with drugs. And it was interesting because basically they didn't talk of anything but illegal drugs. So drugs are only illegal drugs. And that has generated this imaginary in society that when we talk about drugs, it's illegal drugs. The perception that drugs inevitably lead to personal and social deterioration was endorsed by a third to a half. 16% believe that any use leads inevitably to addiction. And there were narratives such as, drugs are like a cancer, the cancer metaphor that eats you up, that second by second eats up your youth, our youth, and our society. So, the worst thing is that this stigma is really perceived in treatment participants as well. And from an exploratory study conducted with people that had been in abstinence-based, mostly faith-based treatment programs in Puerto Rico that predominate and are mostly residential, and were now in methadone, we asked them about their previous experiences in treatment. And what really was very poignant was that experiences with prior treatment were associated with punishment, disciplining, and highlighting the participants' flaws. It was really based on your flaws and not on your strengths. And this help was not what clients really expected when entering into treatment. They really came out with feelings of anger and frustration, and that really affected their treatment retention. So why is stigma so pervasive, and how is it constructed? Well, we began a study of the media, print media in Puerto Rico, and we decided to look at, because the media is has an integral role in shaping public opinion and policy making, we decided to look at what newspapers in Puerto Rico between 1950 and 2010 had to say about drug use, drug users, and drug treatment. The dominant portrayals were of the drug user as criminal or morally deficient, and the methadone treatment was very demonized. And the addict is the product of the deteriorated family values or extreme poverty, and if methadone were effective, the federal government would offer it in hospitals. I mean, this is the kind of thing that stemmed from this 1970 article. If you summarize the findings, drug users are described as dangerous, emotionally ill, vicious, bewitched, cursed, gangsters, rapists, dangerous, contaminated, without religion, so religion is the saving blanket, impulsive, they're a threat, they're sick, they have an inferiority complex, once again, they're dangerous, filthy criminals, homosexuals, young, or university students. So the discourse from the 50s to the 70s has been evolving a bit, but dangerousness stands out as something that is present regardless. It's timeless. And this, believe it or not, was an effort that the government in the early 1990s undertook to expand access to treatment for people that were out of treatment and had a drug problem. So these were the people that were found to be using illegal drugs, and this is how they were taken into custody to send them to treatment. Wow. Now, I'm almost done, but I want to raise this very particular case. It's very, very, very pathetic. This is a young woman from Vieques, one of the islands in the Puerto Rican archipelago, who was incarcerated after her third offense, possessing marijuana. The first time she had a few joints, the second time well, then the third time as well. The first two times she was able to go to quote-unquote treatment instead of incarceration, but the third time, you know what she did? She declined. She said, no, I'm not going to go to treatment. I would rather go to prison. That's how bad the treatment experiences had been. So she goes to prison, and what happens is she gets into a struggle with someone who was attempting, accosting her sexually, and she was killed. So she got a death sentence for carrying low-level marijuana possession for her personal use. Now, why would anyone in prison when they could go to treatment? Because treatment is highly stigmatized. That's why. And we also have a problem in that we have this persistent gap between the need and treatment availability that was kind of pointed out today as well by Mr. Botticelli. And in Puerto Rico, we already showed you there's only capacity to treat 8% of those in need, whereas in the US, it's about, the gap is a little less, but about 10% have received, only 10% in 2013 had, in 2011 had received treatment in the specialized services sector. So our common concerns. There's the ongoing practice of relocating Puerto Ricans who inject drugs from the island to the United States for drug treatment. And this generates a population of people that are coming into the United States through a process that is most times sponsored even by municipal governments and the police. So we don't have enough treatment, we don't want you loitering, we don't want to see you in the community, your family tells me you're suffering a lot, so how about if we ship you out? Let's send you to treatment in Delaware, New York, Connecticut, Pennsylvania, or wherever in the northeastern coast, and we'll pay a one-way trip fare for you to get there. Now, what happens is that this relocation is not guided at all by any information as to where you're sending these people. And basically, there are many of these treatment facilities, quote unquote, that have a detox unit, and then a home that is overseen by a Christian minister, residents apply for Medicaid and other assistances, and the benefits going to the owner of the center. But because treatment consists often of prayers and applying shaming techniques, and Rafael Guerrera was here and Camila Hetria both have published on this, what happens is people abandon treatment, but they abandon treatment without any possibilities of receiving any other sort of social assistance in the States. So we know that this is a problem, and it's a problem that you all will have to face, because these are people that are in your backyard. And the thing is that a cover article we saw in Pennsylvania last year was published in the local Hispanic community newspaper, and they referred to a group of 200 homeless individuals with SUD, including many from Puerto Rico, as zombies, further contributing to the stigmatized identity of drug users. So, even though we're a forgotten island, this is my closing. Even though we're a forgotten island, in the sense that those of us that have these possibilities of assuming responsibilities within the island, that have the capacity to advocate for treatment and have been doing so for so long, and we really have just made small dents. And the reality is that Puerto Rico gets less Medicaid funds than states. In Puerto Rico, only 13% of Medicaid dollars come from the federal government, whereas in the states, it's at least 50%. We don't, many of the ACA conditions do not apply to Puerto Rico. And on top of that, we have no way of fighting in Congress to be really, to be able to obtain the same level of federal resources that all the other states have access to. So what can we do in the meantime? And we hope that by coming together here at this important conference where you are so committed to education and harm reduction, that we can understand we need to educate the media, to address the consequences of enacted and perceived stigma on persons who have experienced treatment as a degrading and dehumanizing situation and condemn it. If we end up serving here in the state someone who abandoned one of these horrific treatment centers, we should be able to be actively involved in denouncing this, assure that the workforce is properly trained regarding stigma and its consequences, and we should make sure that stigma does not sustain policy decisions anymore. The allocation of resources should not privilege ineffective and costly interventions that are harmful under the guise of attaining public safety. And this is the price we have paid, and that's why so many people feel threatened, because since it doesn't work, you end up with more crime surrounding you and more fear for your safety, and you leave the island to some haven in, most likely in Central Florida. Okay, so the woes of Puerto Rico, to finish off, we do hope that as we demand, we really evolve into a demand reduction priority, we will have less crime, less need to divert scarce public funds for prisons, courts, and police, investment in building human and social capital, less death of males in their productive years from homicides, AIDS, and the consequences of chronic HCV, hopefully a society that places the right to health as a priority, and hopefully a return migration and greater resources to renew the enchanted island, and I really do hope we can count on you.
Ladies and gentlemen, help me in saying thank you very much to all our speakers. Right now, we're going to have my fellow co-chair come up, Terrell Jones.
Hello again, everybody. I'm not going to take much time because we know people want to go to lunch, eat, spend a long morning. So a few minutes ago, Charles King came up here and talked about the ending of AIDS. This conversation took place 6 years ago on a bus going to Rikers Island. There were 3 individuals sitting there talking about how can we do this. This was the initiation of the peer network of New York. We need to remember that the peers are still the front line out there fighting this epidemic. And it needs to be acknowledged for the work they do.
Yes.
Of course, so many of us lost family members, friends behind this epidemic. Especially me, I lost 2 family members. So, the idea came into place that one day they were sitting at Wall Street, on Wall Street, talking about how can we get this thing done. I want to bring this young lady up right now, Ms. Ann Siegler, who played a very interesting part in getting this.
Thank you. I don't have anything prepared. I don't want to say anything except we're here to support you guys and we're so thank you.
We love you!
So the peer network has been together for 6 years. We have had 2, 3 conferences, picnic, and we are devoted to educational, skill capacity, and professional development of our peers. One of the things that I just really want to talk about quickly is that there have been a lot of changes going on with the federal government, funding for peers, and a lot of exploitation at agency for peers. And this needs to change. Peers need to be respected for the work that they do out in the field every day, rain, cold, sleet, heat, whatever. They need to be treated with respect in their agencies, and this is one of the reasons why we were formed, to make sure this is happening. Another young lady I would like to bring up, are you here, Ms. Wright, Monique Wright? Can you please come up front, please? Well, Ms. Monique Wright is not here. I guess she got, things to do, but she is the coordinator for the New York City Department of Health, which now she oversees and help out with the running of the peer network. So move right along quickly. I want to bring you up to date. We were asked to come down to Baltimore to promote the Harm Reduction Conference and to do some work out here. Came out here and saw what needed to be done, and we recruited 2 young ladies from Baltimore to assist us in this. So we bring a Carmen and Deborah, they're from Baltimore, you know what I'm saying, and
Well, I would like to say that I've been in Baltimore for, gosh, I think it's been like 12 years now, and closely involved in the sex work industry and intravenous drug use. Obviously, I've seen a lot of things that could have been improved had I or my peers known about harm reduction. I've recently been afforded the opportunity to go to New York and check out probably hardly any of what's really going on with the harm reduction in New York and the peer network of New York. And I believe that if we could get that, even half of that going on here in Baltimore, that we would be saving toes and fingers and arms and legs, and most of all, lives. And I absolutely know that's true. If we do that, the streets of Baltimore will improve. And if we improve ourselves, the stigma that the community has on us will change. It has to start with us. Absolutely. It is us first, and then people will view us differently. And we must take this responsibility together. We've got to get together as peers and work for the community to believe in us. Improve Charm City. Go Baltimore. Harm reduction will improve Baltimore. Absolutely. Thank you.
Hi, I'm Carmen. I'd like to thank everyone for coming, and it's good to know that there are people out there that care for people who haven't learned how to care about themselves. Amen. Baltimore is having a very bad one for us here. The users here don't have any say-so. They don't even know that they have power. There's power in you. And that's why we're trying to get the Pure Network and Harm Reduction Coalition to start a program here. We're not trying to do it. Because someone is a user, it doesn't make them any less of a person. And I was also afforded the opportunity to go to New York to see their program. Awesome program. I didn't know there was so much strength in us. You know, and it has afforded me the opportunity to know that I'm not standing alone, and that feels good. That's right. I'd like to say thank
you. We would like to introduce to you two young ladies who work real hard for the Peer Network and for their said entities, Ms. Tanisha Jones and Ms. Marilyn Scales.
Baltimore to do outreach in the to sex workers and drug users, right? I was totally heartbroken when you see someone with an abscess in their arms and won't go to the hospital because of how they're treated. The stigma. So we all matter. It doesn't matter if you're a drug user or a shopping aholic, whatever it is, we all matter. Yes, we are. But, you know, it just totally broke my heart that someone would risk their life so they don't have to face that stigma. And then second of all, the next day we met with the community. It happened to be that one person showed up. Good enough us. That's right, one. But when I was speaking to this young lady, she would speak about herself in such a negative content. That broke my heart. I'm very emotional. I cry all the time, especially when I'm dealing with the community, because I'm very passionate. But by the end of that hour, her language changed. She was talking about herself. She mattered. Instead of heroin junkie, addict, she was using heroin user, cocaine user, sex worker instead of hoe, prostitute. The lingo alone helps bring somebody up. That lady had courage that day because she started talking about herself in a whole different light.
and I'm very proud of her. And I look forward to coming back to Baltimore and doing some more stuff, because Baltimore needs it.
Yes, yes, yes!
Really needs it, and baby steps, but we're going to get there together.
We here, Baltimore, we here. We love you.
Thank you!
Ladies and gentlemen, real quick, I know it's a long morning to come together, but real quick, one thing that I want to say is that a lot of times when we come to these conferences, we come for many different reasons. Right? Some of us come for the first time. We have never been. Some of us come to see friends that we haven't seen in a long time. Others come because we want to hear what's going on across the country, across the nation, and all around the world, and maybe catch something new that we can take back to our communities, take back to our agencies, sometimes just take back something for ourselves. From every conference that we all can learn something. And with this conference here, the only thing I'm going to be able to say is, you have heard the title, you know this about, but for right now, it's starting from this point on. And like Maggie said, let's do it! Enjoy the conference. Enjoy yourself.